So I'm going to, at the end of the day, obviously have to modify your talk slightly from the talks that have gone before, so I may go more rapidly through some bits and slower through others. So I'm talking about how signatures could be useful in the clinical context. I'm a medical geneticist, but I'll try to give a view that also includes pathology and some treatment. I'd like to thank Paz here in the audience, because he's really the person who introduced me to this field. So we just heard about pathology from Manel, and of course, it is the classification specialty in medicine, par excellence. And of course, it's been, as you know, historically been morphology-based. But for some time, we've actually known that there are signatures that can be extracted in the path lab. And it initially started with DNA work in the 1980s, when you had to sequence or get sequences from DNA from normal and tumor tissue, but later was replaced by immunohistochemistry, which became really an essential way for pathology labs to contribute to the identification of those more likely to have germline mutations. And it's interesting to the history of how this has, got into the synoptic reports. It's taken many years, in fact. I could never persuade the pathologists at our institute to do this until the drugs came along. And as soon as the drugs came along, then the oncologists started demanding this test. And now, of course, it's pretty much routine for any tumor where there's a question of therapy or advanced tumor to look at mismatch repair deficiency straight away. So that's kind of a signature straight away. And then I thought about this in terms, I was at a talk about brain tumors a while ago, and I was listening to the talk and thinking about how, in fact, with small blue round cell tumors, it's been classically very difficult to know what they are, and also brain tumors, it can be extraordinarily difficult to classify them. And molecular characterization became now very much part of the classification. In fact, it's appropriate now we're in IARC, but the WHO classification of CNS tumors is now fully integrated with molecular work. And this is from David Ellison, where he produced this nice example of how Google used features, data layers, to build up your final map. So similarly, you can use the features in the tumor, including sequencing, to build up the final map and an integrated diagnosis. And the idea is that you combine the tiers in each of these groups here to come up with an integrated diagnosis. And how did this work, for example, more practically? This is what the reports at St. Jude, for example, actually look like. They have these features indicated here: molecular alterations, pathology, tumor grade, and then the comments below will have significant detail about what was done in the lab to identify what type of brain tumor, for example, we're dealing with. An example of this would be medulloblastoma, where it's been retransformed by molecular methods. There are several subgroups, 3 main subgroups, but also grade can be important. And then indicating in the report what was the methodology used. And that comes back to the point about standardization. And I'll come on to that a bit later. So how could you get this into the signature? How could you get this report signatures into a path report? Well, obviously pathology is in a unique position, but as we heard about this issue of standards, and there was a paper that just came out in Nature Communications from Maurer et al., where they looked at trying to pick out signatures in multiple myeloma, where they saw some of these flat signatures like 3, 5, and 8 were attributed initially to signature 3, but it turned out that, in fact, that there wasn't really a signature 3. There was no evidence for BRCA deficit in these tumors, which actually was a miscalling. So the idea of maybe Paul can initiate this. There could be a sort of a Lyon criteria that would be based on standards that have been produced by a group like this that would then be promulgated through pathologists and perhaps get into a synoptic report. And there are some caveats and complexities, because the tissue context is not just the sequencing, but the tissue context seems to be important. This is from Naz Rahman's group with Ludmil's assistance, in that they were looked at the TCGA data set and showed, for example, that having a germline BRCA mutation by itself doesn't necessarily mean you're going to have a strong signature 3. It's shown here. Only in those tumors, such as breast and ovary, that are canonical parts of the BRCA phenotype, did they see this. They didn't see a high signature 3 when the mutations were occurring in other tumors. So that actually goes back to this point that people have been offering many American labs offer, testing of BRCA1/2 in people with sort of other cancers and find these mutations and assume that it's actually causing the cancer. And this has been shown even more clearly in a paper that actually came out yesterday. So this is sort of literally hot off the press. So from Barry Taylor, where you can see here that this is just showing here that the germline versus somatic. There are a lot of somatic, for example, uterine sarcoma, BRCA2 deletions occur in 6.5% of the tumors. They're always somatic, whereas, of course, in ovary, they're nearly all germline. And even in some tumors, like lung cancer, you actually get loss of the mutated allele very frequently, much more so than in BRCA tumors. So there's other drivers, maybe on chromosome 17, that are actually occurring here and driving the loss. And HRD, as shown in the previous study, HRD is much more frequent in the BRCA tumors, which are shown here, as opposed to here. It's basically how high up this graph are you on the left-hand side is the HRD score. So you can basically see the higher up you are, the bigger the score, and you can see that there's really not much difference between germline and somatic, shown in black and white. There's a very big difference between whether or not it's a traditional breast ovarian cancer or maybe pancreas, or whether it's something else. So the context is going to be critical in interpreting these results. Interestingly, just as a sort of a sidebar, it turns out that in fact you don't seem to need, in this case, biallelic mutations in BRCA1 to get a response to PARP, which is a sort of an interesting finding, and no evidence for a good response to Pembro. So where could we go with this in terms of prevention? Well, clearly identifying people through family members, for example, if their family members have been picked up by some kind of mutational screen and have a signature that indicates mismatch repair, for example. But there's even attempts now to use actually high mutation burden in polyps as a starting point for prevention trials, and I believe there's one starting in Columbia University next year. What about early diagnosis? Well, similarly, I think we'll be hearing about this tomorrow, but obviously, if you can pick up signatures in normal tissue of people at very high risk for cancer, either through known susceptibility or through exposures, obviously this could lead to early diagnosis. So there's really great opportunities, it seems to me, here across the spectrum of management of cancer. A good example of this would be the basic excision repairs, genes where they each have a different signature, and we now know that in fact these genes are responsible, unlike the BRCA situation, for actually quite a number of tumors that don't fit the normal spectrum. And we some years ago found a patient with a breast cancer who had an NTHL1 mutation and postulated that this would actually turn out to be a breast cancer gene. And now, as we heard from Ludmil, now it has its own signature 30, and so on. And there are some signatures that are absolutely characteristic of certain states. And this was a nice paper from Brittany Campbell, where they actually, this is the summary, where they actually looked at hypermutation and what they call ultra-hypermutation. And what was interesting about this study in particular, there's the hypermutant group. But if we look at the ultra-hypermutant group, they're all caused by germline biallelic mutations in mismatch repair genes, followed by poly mutations. And they're nearly all brain tumors. And this is essentially diagnostic of the syndrome. You wouldn't actually need to sequence any DNA of any children beyond this. If you find this, they have a mismatch repair mutation. This seems to be largely true. It's much rarer in adults. There are some exceptions, and this is a case that we got involved with of a family family from Spain with a very large, unusual cancer phenotype, with this woman here with 5 or 6 different cancers. The main thing was polyposis, but it didn't look like a polyposis family. We found a poly mutation, which was actually VUS, never been seen before. This woman had breast cancer, and she had 280 mutations per megabase. And then this is where Paz got involved, and J.G.L. Kim, and when we looked at the signature, there's this signature 14, which of course is the combination of a Pol-E plus MMR, so the reverse process to this. This is germline Pol-E, then driving a signature that actually is ultra-hypermutated in a breast cancer. So again, you can see how this kind of approach, you could almost like reverse genetics. You could have found this first. We didn't, but you can imagine you could have worked out backwards what the matter with the person was. So what about for treatment? Well, I've talked about MSI, which is a classical example where now it's sort of, as I say, it's now routine to order this. So can you imagine in the future that ordering a signature could be a routine test? It seems to me not implausible. Because of outcome, which of course is what most people care about, does it make a difference to the person's outcome? This is the sort of BRCA and friends. Adapted it to add BRIP1, which may or may not be a valid addition, but these are the classical genes, which are, interestingly, of course, the proteins all interact. And it's been shown that having high HRD, for example, does seem to indicate a better response to certain therapies. Signatures not present in monoallelic inactivation and not present with some of the other breast cancer genes. So, you can imagine that it's not just BRCA, there could be other genes in the same pathway that could be implicated, although of course they'll be much rarer when you get beyond BRCA1, 2 and PALB2, but they are probably important therapeutically. And then there's the question, particularly coming to IARC and thinking about diversity, of the fact, what do we know about, for example, triple-negative breast cancer in African Americans, where it's much more common, 20–30%. Paz and others have shown that the mechanism of causing HRD in these tumors may be different, but do we know whether this is going to be the same in other populations which haven't been studied at all, Puerto Ricans, other Caribbean populations, and many other populations in the world. So it'll be important in the Mutograph project to see how this works across different populations, not obviously in breast cancer, but in other cancers where there will be similar signatures. And of course, therapeutically, we now know, now that there's base excision repair defects have a signature, so that lethal approaches could be employed to try to take advantage of these fairly dramatic effects that result from having these genetic defects, and also often the mutation rates are very high, so this could in fact be a tool to derive new therapies. And there can be unexpected extensions of HRD, because we would never think of the Krebs cycle as a classic HRD pathway, but in fact in a recent paper it shows that the tumors with SDH mutations in the germline actually seem to be susceptible to PARP drugs. I don't think there have been any patients in trials treated, but there's a question of whether this could improve outcomes. So this is an interesting point, that it may be actually both in one direction, that the signature doesn't going to play out in BRCA in the wrong cancer, but actually it does play out in a completely different gene, in a completely different setting. So how could outcome be influenced as a summary? Well, obviously early identification of risk, early intervention to prevent precancer progression in affected persons. Obviously it's really chemotherapy choice, and the interesting question of second primary cancers comes up because of all the recent papers that we heard a little bit about earlier. I'll put the slide up, but I won't go over it because you discussed this. This very same picture was shown earlier by the progenitor of the picture, so I won't try to explain it. But the point is that these signatures are clearly now emerging, and for example, if a person develops a second primary cancer, is it because of a germline variant? I mean, there's three possible causes of a second primary cancer. Either it's environmental, or it's caused by the physician, or it's caused by underlying genetics. And you can distinguish between those 3 points probably using signatures. So it'll be very interesting to see how this plays out in the next few years. What about for variant classification, which is really where I got interested in this whole topic with Paz and other people. So this is the figure from the paper where Paz and colleagues used the TCGA data to try to classify BRCA1/2 VUSs, and essentially we're able to sort of, in a pathway manner, able to ask the question, was there any LOH, for example? Was it of the right allele? Was there any evidence for another mutation in another pathway gene or in the same gene? This allowed you to, for example, if there were no additional somatic null mutations in the same gene, then none of these turned out to be pathogenic, and that was accurate. And if you went down this route, if there was high SIG3 levels, and there were no discernible lesions in other genes in the same family, such as I said, BARD1 or BRCA2, for example, or PALB2, for example, then 4 out of the 5 actually were thought to be pathogenic. So you can see, just using this sort of approach, you could actually help to classify variants, which otherwise might be tricky, because after all, segregation is very powerful, but in many cases these are unique mutations which you don't have information for. Other people have done the same approach, and it seems to be getting some traction. So I put together this sort of concept of how you might do this from whole genome sequencing data. if you have, first of all, you have the germline data, and then you layer on the tumor data, and then you add in the signatures, and then you add in methylation, and from this you could take your variant and sort of pass it through these filters and end up with a core where VS means very strong support, N is neutral, weak, it would be W, and very weak. So, for example, take this, let's start with a VUS. You have a VUS where there's two mutations in the tumor, there's evidence for signature 3, there's methylation is present, so that would be weak evidence because probably methylation is driving the effect. On the other hand, if methylation is absent, then that would then push you towards it being strong or very strong evidence that this VUS actually was pathogenic. And you can also apply this to other genes, of course, that don't necessarily are not HRD genes because there'll be other signatures, so you can play it down here. And I've just mentioned that you could have MMR, POL-E, MYH, NTHL signatures, whereas if there's no signatures, again, it's more likely to be one of the genes that don't seem to have a known signature at the moment, ATM check 2. So the interesting point is, after 25 years after BSA 1 and 2, what's in this group here? Because we've got, if there's methylation of these genes, then it's unlikely to be a new gene. So what is this group here? And essentially the conclusion of the paper from the Australian group was actually basically there's nothing there. And so I think we can sort of announce the end, perhaps, or nearly the end. There's not going to be any more HRD genes using this kind of approach that will contribute vastly to breast or ovarian cancer susceptibility, but nevertheless, this kind of approach could be pretty useful for classifying variants. So I will just come to a conclusion by saying that, obviously, as you know, the signatures could influence management. It's in several classes of genes, both at the level of classification, at the level of prevention, early diagnosis and treatment. I think across the board there could be a role. And of course, I would like to think that they could be used to help to resolve uncertainty for VUSs. So here's some questions that perhaps come out from this. Can we use circulating free DNA to infer signatures that may be therapeutically more relevant? What about in lower income or low to middle income countries? Obviously a question that's very, very pertinent to the whole Mutographs project. And can we incorporate really coming back to Manel's point, can we incorporate signatures into clinical trials such that we can really test whether these approaches will actually work? And I will stop there. Thank you very much.